Thank you. Thank you. Good afternoon. I'm thrilled, although it's also a little jarring, to come back to campus after, I think I left here in 2001, and quite a bit has changed, although some things have stayed the same. Back then I wasn't as into walking as I am now, having spent time at a foundation, and so it actually struck me how far apart the buildings were. I drove everywhere, and I remember parking lots were very important at the time, and now I think there are fewer parking spaces, although you have garages maybe, so you have a little bit more room. Anyway, I was just thrilled to have been invited here. I'm really excited to be part of a session on innovation in public health. As Dr. Quinn said, my name is Lori Melichar. I am now the team director for the Pioneer portfolio at the Robert Wood Johnson Foundation. So I live in New York City, and I commute to Princeton most days because, thanks to the University of Maryland, I have a great job. So my job at the foundation is to work with my colleagues to discover and explore pioneering ideas. Now, for those of you who may not be familiar with the Robert Wood Johnson Foundation, we're the only grant-making organization in the United States that is dedicated exclusively to improving the health and healthcare of Americans. And we've been working on this mission for over 40 years. We believe that we and those that we support have been integral to changing the country's views and approaches to health challenges such as access to healthcare, childhood obesity, and tobacco cessation. Now, last month, after an extensive strategic planning process, the Robert Wood Johnson Foundation announced a new set of strategic priorities, which you can learn more about on our website, rwjf.org. And if I had chosen time to come and talk to you before February 11th, I would, again, have described our mission as to improve health and healthcare. And that's still our mission at its core. But I think increasingly when you hear about the Robert Wood Johnson Foundation, whether it be on NPR and talks such as the one that I'll give today, you'll hear us talking about our work in a new way. We are now focused on efforts to contribute to advancing what we're calling a culture of health, a massive challenge that we hope that you will all join us in trying to achieve. So what exactly is a culture of health? A culture of health is one in which being healthy and staying healthy is an esteemed social value, in which the health of the population guides public and private decision-making, and where geography and demographics do not serve as barriers to good health. A culture of health is one in which individuals, businesses, and governments work collectively, breaking down unnecessary silos to foster healthy communities and lifestyles. A culture of health is one where the economy is less burdened by excessive and unwarranted healthcare spending, and in which we are all supported to make proactive choices that will improve our health. Now, there is no doubt that this is an ambitious vision, and it's a vision that we will only be able to achieve if we take chances and consider completely new approaches and styles of thinking, including those that will come from outside of health and healthcare. So over the next few months, the Robert Wood Johnson Foundation will be developing a strategy for advancing a culture of health, and it will be multi-sectoral, and it'll be multifaceted. And as we execute upon this strategy, we'll need to keep our eyes and ears open to emerging trends and actively anticipate the future so that we can evolve our strategies and make sure that we take advantage of the most cutting-edge thinking. It will require us to explore pioneering ideas. Now, I'm using the phrase pioneering. I'm not using innovation. We've been funding and supporting innovation across the foundation for more than 40 years, and we will continue to strive to work with the brightest, most committed, creative, innovative leaders on a range of health challenges. And you can learn more about all of these individuals and the work that they do, again, by visiting our website. But what I want to talk to you today is about our investment strategy to support ideas that go beyond innovative, to support ideas that are truly pioneering. So I'll spend a few minutes talking about what I mean, because it's in my experience and not everyone agrees on what qualifies as truly pioneering. And there's no doubt that many of the proposals we receive should be considered truly innovative. Proposals to develop new products like a smartphone app that tells us when to take our medication, and proposals to improve on the status quo by creating systems and projects that help us figure out ways to get things done faster and more efficiently and remotely. These are great ideas that are really innovative, but they aren't proposals that we support as part of our small body of pioneering work. To guide us in our search for pioneering ideas, we developed a list of criteria that we still use today to describe what we're looking for to the outside world, but also to use as an internal tool when we review and discuss proposals. So I thought it would be good for me to share this list with you today so that you're clear about what I'm thinking about when I'm talking about looking for pioneering ideas. And during the Q&A, I'd be interested to hear what your reactions are to that list. So we believe that for something to be pioneering, it needs to be original. And this could mean it's new, like it has absolutely never been done before, or it could be it's an established idea that someone is applying in a novel way. We believe that it needs to be unconventional. It should confront how people act as well as how they think, and it should look at a health challenge through a different lens than one that is being applied currently. It should be transformational. While they may have a lot of value, we don't believe that ideas that incrementally improve health or healthcare are pioneering. We're looking for something that will have a radical impact. And we look for ideas that are interdisciplinary, bringing in perspectives from other industries and other fields, or bringing in unusual suspects to help tackle the challenge. This belief has led us to have conversations with designers, with neuroscientists, with epigeneticists, and corporate CEOs. And finally, we believe the idea should be sizable and transferable, meaning it addresses a large-scale problem and could be adapted to other contexts or address a wider range of issues than what we might initially be exploring. Oh, and finally, we think the idea should be sustainable. It should have the potential to produce outcomes that are valuable enough to be continued, supported, and adopted by others. Now, we don't necessarily require that every idea in which you invest encompass all of these qualities, but many of them do. So I work at the Robert Wood Johnson Foundation with a group of colleagues to discover and explore pioneering ideas and ways of thinking, and then also to share that learning with others, particularly our colleagues within the foundation, but also increasingly with those who might benefit from some new perspectives. And where the other teams are working really hard to combat childhood obesity, improve the value of health care provided in the United States, build demand for healthy communities using the most innovative and effective programs, models, and tools that exist to accelerate our path towards a culture of health, a few of us have the opportunity, indeed the responsibility, to be experimenting with ideas that may not advance anything and may produce true breakthroughs. So at the end of the talk, I'm going to encourage you to join us in our search for pioneering ideas, whether they be your own or the ones of people that you encounter. And to bring you on board about how we do that, I'd like to spend some time talking about how we've been traveling along this path of discovery and sharing some examples with you of the past explorations that we've done of some pioneering ideas. So through the conferences that we attend, the individuals that we encounter, and the ones that we include in our online networks, and also the content that we consume, we are really intentional in our efforts to expose ourselves to people and to ideas that are outside of our conventional areas of interest and expertise. So we discover a new idea, a new way of thinking, or maybe just have what Stephen Johnson has coined a slow hunch, through a conversation in the hallway when we're at a conference, or by clicking through a link tweeted by a colleague or someone in our network, or by listening to a podcast. And though we receive more proposals to produce incremental change than to really experiment with pioneering ideas, even through the Pioneer portal, we do find pioneering ideas in some of these proposals. And we get some sparks and hunches from those as well. So we talk about these sparks, slow hunches, ideas with our colleagues who inspire us to dig further and discover more, or perhaps just encourage us to let the idea fizzle. And then for the sparks that turn into ideas, we spend time talking with people, conducting research to understand what the questions or the hurdles are, and how this new way of thinking could be applied to our health challenges. And once we are convinced that we can articulate why the idea is new and potentially really important, we begin by exploring, by making an investment that allows others to explore the idea in a small way, to understand what it would take to realize the full potential of the idea, and eventually to assess the potential of the solutions that might come from that. And while these grants are underway, and as they conclude, we seek opportunities to share this learning with our colleagues at the Foundation and also more broadly. And in the past, we relied almost exclusively on publications and reports to convey the findings to our academic and our policy communities. But just as we are trying to engage unconventional audiences in our discovery, we're increasingly also using unconventional strategies to reach audiences when it comes time to share our learning. We want our lessons to reach those who may not even be looking for them. So I'll come back to influence a little bit later in the talk, but I wanted to share a couple of examples about how we discover, explore, and learn from pioneering ideas. So I mentioned that we look for sparks at conferences with unconventional speakers and at meetings of unconventional groups. So a colleague of mine at the Robert Wood Johnson Foundation, Jody Struve, attended a maker fair. Do you know what that is? So maker fairs are events where, that are intended to celebrate the DIY or the do-it-yourself spirit. Some people have called them science fairs on steroids. And my guess is that you'll hear more about them because the White House has actually announced last month that they would hold their first ever maker fair later this year in an effort to promote entrepreneurialism and careers in design and engineering. So anyway, Jody was fascinated by this experience, and she came back to the foundation inspired to think about how it could be applied to our work, and her inspiration was really infectious. There was something that she said. She said, Maker Faire celebrates the hacker who works around the system to make things work. And it triggered me to think about something that I had done in the foundation through the Transforming Care at the Bedside program. So the goal of Transforming Care at the Bedside was to recognize and engage nurses and other frontline staff who were, through their own ingenuity, transforming health care delivery models and systems. And the mantra of that work had always been, workarounds represent a system failure. It was the work of the nurses, therefore, to eliminate workarounds and fix the system. Nurses would hide their workarounds from us when we had site visits, and when pressed, we also found that they were hiding these innovative solutions from their managers as well. Essentially, they were ashamed of what they were doing when perhaps, as I was listening to my colleague Jody talk, I thought maybe they should have been really proud. So based on the initial hunch that there was something there, we reached out to the folks who ran Maker Faire, and they sent us to Jose Gomez Marquez, who runs the Little Devices Lab at MIT. And in talking with my colleague Paul about the progress of this idea, he told me that he had come across Jose's work applying maker thinking to the development of medical devices, and he had already invited him to be the foundation's guest at TEDMed. And in Paul's research and when they had spoke, nursing had never come up. But when I met Jose at the meeting, his name tag said, "Ask me about MacGyver nurses," and I knew that I had found a partner. So on our walk to dinner in San Diego, Jose said that he shared my hunch that nurses had already embodied the maker spirit. So there was something there, but what could we do with it? From there, the Maker Nurse project emerged. It was time to explore. So Maker Nurse, which is led by Jose at MIT and his colleague Anna Young, has collected stories from inventive nurses across the country to better understand what drives them to innovate. When they find Maker Nurses, they interview them to better understand, to help us learn, because we want to better understand what drives a nurse to be a Maker Nurse, what qualities do they have as a person. Are they more willing to buck the system, or are they disinclined to wait for somebody else to do something that they know needs to be done? And we also really want to understand the role that the environment in which they work plays. Do their employers support them to be innovative? Do they feel like they have the authority they need to make the decisions about how to best do their jobs? And we want to understand the barriers that these Maker Nurses encounter. And with these answers in hand, we want to understand if there's something that can be done to remove these barriers, to nurture and showcase this creative talent, to compel more nurses to become makers. So we want to create a Maker Nurse movement. And we're still deep in the learning phase of this work, and we don't know yet what it will take to realize the full potential of the idea of a Maker Nurse movement and its implications. But if it looks like the idea has legs, we're planning to continue to explore this approach by creating maker spaces. These would be spaces where nurses and other frontline staff can come together in a hospital to create their own workarounds, and we're planning to do this, try this, prototype it in up to 3 hospitals. And if this works, if we find Maker Nurses, if we find a hospital that's willing to convert space into a maker space, If nurses and others find the time to come together and build innovation in that space, then we will learn from that experiment. And we will share that learning with others through the Maker Nurse website and through other venues so that other hospitals can be inspired to create these spaces themselves. And if it doesn't work, if this hunch doesn't pan out to represent a significant number of nurses' experiences, we'll also learn from that experiment and share that learning with others so that they pursue more promising paths to improving care and increasing nurse engagement. So here's another example. Nearly 8 years ago, the Robert Wood Johnson Foundation launched Project Health Design to allow us to explore how personal health applications and devices could integrate observations of daily living, such as sleep and eating habits, into both personal healthcare decision-making and also into clinical care. Project Health Design supported people, particularly those with chronic conditions, to collect data and then share that data with doctors. And this project encouraged us to believe that this type of data was valuable, not only for the insight that it could provide to providers, but also for the role that it could play in patient empowerment. So we saw potential, but we also recognized a barrier. It was really hard to get the physicians to trust this data that their patients wanted to share. Now, in the beginning, this was 2006, we never could have anticipated how quickly the field of personal health data would progress with the launch of the personal health data devices that are happening at really warp speed. And in 2012, another colleague of mine, Steve Downs, called me when I was on maternity leave because he wanted to explore how we could use the data that was being tracked through the personal devices for research. So we originally thought that maybe we could ask these companies that had been talking with us about their willingness to share the data, that were creating these devices, and we were going to ask them to give us their data. And then through a call for proposals, we would ask researchers to tell us how they think that they could use that data. And then we would support the researchers who had the ideas that we thought had the most value. But then we realized there was just really too much that we didn't know for us to launch into this kind of program. Would the companies really be willing to give us the data? Could the companies share the data if they wanted to? What were the terms and conditions they had provided to their users regarding the use of the data? And in what form were the companies collecting the data? So we needed to explore these questions and more before we could dive in too deep in this area. In 2013, the Robert Wood Johnson Foundation, in partnership with the California Institute for Telecommunications and Information Technology at the University of California in San Diego, launched Health Data Exploration. Now, there are two end goals to this project. We want to bring companies who have the kinds of data I just described together with researchers who can analyze these data for new insights. And we want to have the people who are creating these data about their daily lives and routines and observations, we want them actively engaged in generating hypotheses about what we may uncover that could really hasten our journey towards achieving a culture of health. So to get there, we've surveyed companies, researchers, and individuals to understand what is possible and also to understand what we need to overcome. And we have the results of this exploration, and we're going to be sharing the key findings from the survey, I think next week actually, as well as what's going to emerge from an RWJF-funded symposium that we're funding the Quantified Self movement to host on the topic of making self-tracking data available for the public good, which will take place in April. And we're going to use that to guide several further experiments in this area. In one of those efforts, we're going to work with Roger Magoulas, who is at O'Reilly Media, about the technical, social, and legal challenges of integrating patient-generated data into academic research. And the approach will be, of that project will be to build a health database prototype that will collect this data from sensors, wearable devices, and surveys, integrate it into clinical data stored in electronic health records, and analyze the combined data sets. So ultimately, we think that the work of these pioneers and the learning that comes from it could really contribute to transformational research, essentially changing the sources of data that researchers use, and that it could make research more what we call agile, as opposed to the cumbersome and slow process that it too often is today. We expect to call on a burgeoning community to think about how we can protect privacy and confidentiality, as well as the integrity of the data and the reputations of those who put it to use. And at the same time, we will also likely ask researchers to get more comfortable with putting up what the startup community calls a minimum viable product and lowering the barriers to critique of their research. We will continue to try to understand the unique scientific, methodological, or ethical issues involved in such research, how to handle the intellectual property of the research findings, how and where these data intersect with other forms of medical and public health data, and also, importantly, the quality of data that we think that we're going to uncover. And these are not small issues. Nevertheless, we are confident that these data contain insights about personal and population health, and we are committed to finding them. Now, I mentioned that we receive we accept unsolicited proposals through the RWJF website into the Pioneer portfolio, and there are times when we see proposals from people we did not know, who present pioneering ideas we have never heard of and that we never would have dreamed of, who present feasible, reasonably priced plans for experimentation. And so when we get one of those, we fund it. So I wanted to give you an example of what I mean. In 2004, Ramanan Lakshmanarayan, an economist with a master's degree in epidemiology, had an idea for how we might address the challenge of increasing antibiotic resistance. He was working at Resources for the Future at the time, a think tank that improves environmental and natural resource policymaking worldwide through objective social science research. So he wanted to come at this health challenge from a new angle, from the perspective of a natural resources economist. His perspective on this persistent problem was pioneering. He was looking at the public health problem of antibiotic resistance through an economic lens. And his framing was simple. He suggested that we needed to treat antibiotic resistance as a natural resource that can be depleted with overuse, just like water, trees, and other resources on which we depend. So Ramanan submitted a proposal to the Robert Wood Johnson Foundation, to the Foundation's public health team. And as interesting as this project was, it was way too far off of a strategy of a team that had really embarked on a very specific strategy to increase the accreditation of public health systems across the country. And it was also too far out for the Foundation to support this as part of its general public health work. So the Foundation turned the proposal down. And then a few months later, Ramanan saw an interview with one of my colleagues talking about the Foundation's pioneering work, and he decided to submit the proposal again, this time to the Pioneer portfolio. And Ramanan's interdisciplinary approach struck the team as original, interdisciplinary, unconventional, and potentially transformative. And so we invited Ramanan to come speak at the Foundation. And as a result of that meeting, his modest proposal for a planning grant grew into a much larger, deeper research proposal. And this grew into the Extending the Cure project, which is based at the Center for Disease Dynamics, Economics, and Policy. Now, in 2007, Extending the Cure published a major report that detailed the mounting dangers of antibiotic resistance, projected the economic and human costs, and prescribed interconnected policy solutions. The successful study was done, Pioneer's work was concluded. Extending the Cure helped extend his career and helped raise broad awareness about the growing threat of antibiotic resistance, and it offered a comprehensive solution to address the problem, from better infection control to the development of new, more powerful drugs. Extending the Cure has produced extensive research and commentary on the increase of drug-resistant infections, so-called superbugs, and the cost, both human and economic, posed by rising resistance rates. Its annually updated resistance map reveals alarming trends in the overuse of antibiotics, a key driver of antibiotic resistance. So this research has armed national, state, and local health leaders with valuable information and tools to help better target their efforts to reduce inappropriate use, curb the spread of infections, and extend antibiotic effectiveness. Within months of the report coming out, Senator Orrin Hatch cited the report and echoed its passages when introducing a Senate bill to address antimicrobial resistance. In the weeks leading up to this, Ramanan and his staff had been meeting with members of the senator's staff, thanks to support from the Foundation's Connect program, which helps grantees present their ideas to members of Congress. The Underlying ideas from this project have had tremendous staying power. More than 5 years after the 2007 report was published, Fast Company spotlighted extending the cure with the headline, "We need to treat antibiotics as a natural resource." So this is a great ending for a pioneer story. Perhaps it's not even over. In this story, a report, publications, and presentations with a little help from the Foundation's Connect program had impact and influenced the messages of others. Perhaps even more impactful, the Foundation learned from someone who had never done work in health and healthcare previously that this strategy of applying a lens from a non-health field, this case environmental economics, to health and healthcare was an influential one. So among other impacts, this project influenced the Foundation's decision to invest in MakerNurse, a project which applied the Maker movement lens to the work of a health profession. So I promised that I would come back and talk a little bit about influence. And I'd like to spend the last 10 to 15 minutes of my talk exploring this topic. So a behavioral economics study that's published in an economics journal can help fill a gap in the literature, and if picked up, it can and often does influence policy. A blog post that discusses how an experiment we funded could help colleges encourage students to get flu vaccines can impact outreach activities of a college health center. A face-to-face meeting with an RWJF team that is working to combat obesity that lays out the promise and the limitations of several behavioral economics-inspired interventions to increase exercise and decrease calorie consumption could have an immediate effect on the strategies that are in progress and possibly dramatically accelerate the Foundation's success and progress. A seminar that discusses how research about behavioral economics might have implications for the work of clinicians, consumers, community health workers, and others, that takes in as much information about the challenges of the field as it produces insight into the work, can have more influence on our progress towards achieving a culture of health. So these alternative emerging methods of communication of pioneering ideas can help us reach those who need new ideas, but are so busy doing work that they don't have time to look for them. To further guide our discovery and exploration in pursuit of a culture of health and determine how best to share what we've learned and encourage others to explore further, we've determined that we need to redouble our efforts to bring in emerging forces of influence. So I wanted to talk to you a little bit about the forces of influence that we're currently exploring to shape values and build beliefs and change actions. And I'd love to hear from you about other forces of influence that you think that we should learn more about. I should be clear from our investment in the Health Data Exploration Project, we are cautiously impressed by the promise of emerging technology to collect and analyze increasingly large quantities of data to help us better understand and address social challenges. When we say big data, we mean everything from the tremendous data sets that are being amassed by those who provide and coordinate and pay for care to the data sets that are being collected by the wearable devices, smartphones, and other tools. They're providing corporations with ever larger streams of data across the lifespan through the course of health and illness and in the geospatial context. We believe the ability to identify health-influencing behaviors down to the micro scale and to use them to construct highly targeted and highly effective interventions also produces a massive opportunity for health management. We seek new ways to surface patterns in both big and also small data to help identify, understand, and target those that we want to influence. And we're working with the folks who helped Obama win the election to see if we can use micro-targeting techniques to get more people enrolled in the health exchanges. We think that these techniques also hold promise to increase vaccination and also to promote public health in other ways. And if you have any ideas about how we might micro-target individuals who can be moved to improve their own health or the health of somebody that they influence in a single action, preferably with a deadline like voting, I'd love to hear them either in the Q&A or afterwards, because we're just getting into this area. We'd like some areas to experiment in. So in shifting to influence strategies that leverage massive amounts of data, we can't lose sight of the people behind those data. So in addition to relying on information to persuade people, we need to get better at exploiting insights from the behavioral sciences to impel people to take action. Most of us don't really know how we know what we know, or why we do what we do, or whether that knowledge and behavior are largely driven from data or a source from other pools of influence like tradition, personal experience, or intuition. But the fact that our health beliefs are not necessarily data-driven do not resist either their resilience or their stickiness. Having health influence today requires converting people, including policymakers, not simply informing them. It's not necessarily that people aren't smart and knowledgeable. The problem is that in the moment of decision-making, we are unduly influenced by short-term benefits and generally have a difficulty factoring in the longer-term implications. At the moment of decision-making, humans generally take the path of least resistance or the path of greatest immediate reward. In the words of Dan Ariely, an early advisor to our investments in behavioral economics, in the future, we are all wonderful people who care deeply about the long-term health and well-being. The problem is we never live in the future. So when we began to explore what behavioral economics had to offer to our efforts to improve health and healthcare, the field was still new and many of our ideas were still untested. After 5 years of discovery and exploration and learning with colleagues from the University of Pennsylvania and from across the foundation, we are now able to share our learning with the field. Behavioral economics is now seen as a viable mainstream strategy for healthcare quality improvement and for combating obesity. Exploring behavioral economics and being really public about our exploration has exposed us to other approaches for behavior change. B.J. Fogg of Stanford University publicly challenged the Foundation's embrace of behavioral economics on Twitter, and since then we've invited him to the Foundation so we could learn more about his own model for behavior change. And we're eager to explore the other angles that take advantage of this awesome power of human irrationality. The engineering of human environments is of utmost importance. Environments and processes that are designed to make it easier and more pleasurable to do the right thing can have a tremendous impact on healthy decision-making. And as we pursue a culture of health that makes it easier for people to pursue healthy lifestyles, that we will need to influence the products, services, and policies of for-profit companies. Markets will always matter. They have always mattered. The products and services Americans can affordably access in the marketplace shape their health outcomes. Trying to correct for market tendencies that discourage healthiness is an important path to influence. Another approach involves partnering with market makers and businesses from the outset. Why not use market forces as a backwind rather than confront it as a headwind? So we have long understood that we need to work through social systems and social networks to create inputs to social change, as well as to reach people and shape their attitudes and behaviors indirectly. Having influence on individuals requires seeing individuals both as free agents, but also as members of groups, and being able to move nimbly between the individual and the cohort as the target for our efforts and our outreach. Being influential in an age of networks, understanding how movements and mentalities can spread through them, requires mastering an emerging body of science focused on things like diffusion models and causality mapping. And the philanthropic sector has really been a slow mover in this domain. The Robert Wood Johnson Foundation wants to contribute to accelerating our collective progress in this area. In many ways, our support of Nicholas Christakis, Damon Centola, Daniel Zuby, and others have strongly impacted what we do at the Foundation. Today, we actively look at how our own networks function and enable us to do our work. We've developed an online leadership network to see how people with whom we at the Foundation are connected with each other, including alumni of our many human capital programs, to better understand how influence spreads. We've used social network analysis in evaluation and experimented using open source free social network analysis software to examine our own internal networks as well as the networks of our grantees. And we're moving beyond learning that health behaviors are influenced through social networks to supporting organizations such as Zuby's Microclinics International, which works in under-resourced communities around the world to leverage existing social networks to actually improve health outcomes in the fight against chronic diseases such as diabetes and HIV/AIDS. through our support of the project I just mentioned, we're trying to better understand the mediating factors, such as how precisely people are connected within their social networks and the demographics of the members, to bolster our efforts at the foundation to influence health behaviors. So I've talked to you about how we at the Robert Wood Johnson Foundation define pioneering and the forces of influence that guide our discovery. Hopefully helps you understand what this all means in practice through some of the examples that I've shared. It's important to remind you that our efforts to support pioneering ideas represent a very small FTE of the foundation and a very small percentage of our budget. And you can learn more, as I said, about the Robert Wood Johnson Foundation by visiting our website. And you may find ways that your current work supports our emerging vision. Hopefully you'll be inspired so that your future work can also help us advance our shared goals. And I also hope that I can enlist you all as agents of the foundation in search of pioneering individuals and pioneering ideas. If you meet pioneers or you have sparks or ideas, if you could send them my way either via Twitter or through my email address, it'd be great. And if you're still not sure what this ask entails, I hope you'll use the time that we have left here together to become more clear. So with that, thank you for your time and attention, and look forward to your sparks.